Welcome back to Skinfluence, the podcast for all things about your health and your skincare. I'm Dr. Dustin.
And I'm Austin Lee, PA, working with Dr. Dustin.
And I'm loving this so far, just the podcast.
The podcast has been great.
Yeah.
I've thoroughly enjoyed it. I thought it'd be way more work or stress, but it's very natural. It's things that we are interested in, and I've enjoyed it.
Same conversations we have with our patients every day. And today the conversation's all about unwanted pigmentation, dark spots, melasma, PIH, all these things on the skin.
All the stuff that we talk about very regularly in clinic.
So today let's shed some light on your dark spots.
Yeah. So there's different types of pigmentation that we see in the skin. Patients will often come in asking, why do I have this dark spot on my skin? And there's many different reasons why we see some of those dark spots. What are some of the most common ones that you feel like you see in clinic?
One of the most common is PIH. The long name for that is post-inflammatory hyperpigmentation, which happens when you have inflammation in the skin. The most common scenario is after acne. And it seems to be more common if you have a darker skin tone to begin with. So when you have an acne bump, a pustule, or a cyst, your body sends in a ton of white blood cells to try to manage that. And once those white blood cells do their job, they don't go back in your bloodstream and get filtered out by the liver or something. They just stay in the skin after they've gobbled up whatever it is, and they die there. Then it's up to another type of white blood cell called macrophages to come and ingest those, and then they just stay there. So it leaves this color to the skin that's not truly melanin pigment, but it is a darker pigment, and it can last for months.
Yeah, it can last a long time, especially with people with acne, severe cystic type acne. People come in saying, what can we do about the dark spots and the acne? And it's like, well, we need to treat the acne, and that will slowly, the dark spots will resolve by themselves. And most often, time is the best way to heal PIH. There are some things we can try to do to help, depending on how deep it goes, because sometimes it kind of can go deep into the dermis a little bit. But PIH is a very, very common one that we see in the office.
I would say the most common scenario is that somebody who has acne, even if we successfully treat their acne, they say, oh, I want to treat these acne scars. Or I get pictures all the time sent to me online on Instagram where people are like, hey, can you help me with my acne scars? And they really don't have any true scarring. There's no texture change to their skin. It's just pigmentation from old acne lesions. And we'll cover all of the ways that you can treat that later on in the podcast. But PIH, probably one of the more common types of pigmentation disorders that we see.
Yeah, totally would agree with you. Another one that is very common in clinic is something called melasma. Melasma, or another term for it, is the mask of pregnancy. We see it happen more often in women, although it does happen in men, and we see it happen in men. But it's that classic kind of blotchy patches of pigment that you'll see on the cheekbones, especially. It can happen on the forehead, anywhere on the face, but usually where you're seeing a lot of sun. Yeah,
it's really frustrating and troubling to women when it happens on the upper lip, because it starts to look like they have a mustache. And that's a common area as well, is to get that really kind of reticulated, lacy pigmentation. And it's so hard to get rid of.
It is very difficult to get rid of because it is the body producing, or melanocytes are producing more pigment.
It's true pigment, and it can lie pretty deep in the skin. So then as we get older, sunspots, lentiginous is the medical term for them. Lentiginous, or a lentigo, a liver spot, all of those types of things. Same thing, called by different names. And these are increase in pigment, and it is more uniform. It's not patchy like melasma is. It's more of a solid dark spot. When we look really close, there's a pigment network, like under dermoscopy, we can see a pattern, but they are much more confluent on the skin than something like melasma with sharper borders.
Yes. Very often you'll see what we call an ink spot lentigo. It looks like you took a pen and just let the ink spill out onto the skin. It has these sometimes jagged looking borders. People come in concerned about those. Very often we see lentiginous on the upper back and shoulders where you've been sunburned as a kid growing up. That's probably the number one place that we see them, but they can happen on the arms, the face, other places like that.
And then pigmentation problems don't just happen in adults, but kids can get them too. And freckles are the most common pigmentation disorder, although it's not truly a disorder. It's a pretty normal response. I had tons of freckles as a kid.
Yeah, I did too. I actually just read the part in Harry Potter, book 5, where Ron is in the hospital. Ron typically has a lot of freckles, and the painting of an old healer, doctor, is trying to diagnose him with some other disease because he has lots of freckles.
Oh,
and I was like, a derm joke in Harry Potter.
I'm going to have to ask my daughter about that because, like you, she loves Harry Potter. Yeah. I think she's read the books 11 times, like all of the books. So I'm going to have to ask her about that scene. I've never read the books. I have watched the movies. I don't know if that tells you something about me, but I'm
not at all.
Not as much of a reader.
Yeah, that's okay.
I read so much in med school.
Yeah, you're just like, you burnt out.
I did.
I get that.
I'm trying to be better now. So freckles happen when the pigment cells that you have produce extra melanin, but you don't have more pigment cells in that area.
Right.
So they're just super active. And most of the time these fade as kids grow and they're not out in the sun quite as much.
Yeah.
The difference being like a mole is in a mole you have tons of extra melanocytes, tons of extra pigment producing cells that also make a lot of pigment. And so if you were to biopsy a freckle, it would have a normal number of pigment cells versus a mole would have tons of extra pigment cells.
Right.
So we talked a little bit about why the dark spots take so long to fade. And part of that reason is because every time you get sun, it's like pouring gasoline on a fire, and it's harder and harder to put it out.
Yeah, and you'll notice the dark spots, especially with certain things like the lentigines, the sunspots, melasma. You'll see that spreading almost of that pigment, and it can be frustrating for a lot of people.
Yeah, I laser my face every year around Christmas time.
Oh.
And this last time I did it myself, which I don't advise people to do, but it was like Christmas Eve, and it was literally like
oh no.
just zapping my own face with the laser. And I hit these lentigines I have on the side of my head like 100 times, and they took forever to heal after that. But you can, if you go out in the sun and you're not protected, that's all it takes sometimes is one time, and those lentigines or other, melasma or things can come right back. If you have PIH, post-inflammatory pigment change, then going out in the sun will make that darker, and it will make it last longer, even though it's not true melanin pigment.
Yeah. That's interesting.
So any other
struggles.
Types of pigmentation problems that you're used to seeing? I mean, we don't see a ton of like ashy dermatosis or pigmented purpuric disorders in the clinic, depending on the region of the country that you're in and the patient population that you see. There are other skin disorders that are due to excess inflammation in the skin. They kind of go along with like a lichen planus type of rash.
Sure.
They're kind of in that family where you get excess pigment deposition. Another one that we do commonly see a lot is pigment on the legs of older individuals. And this is a condition called stasis dermatitis.
Totally.
When you get older, the veins in your legs just don't work as well. Yeah. And as your legs swell, it doesn't have to be dramatic swelling, but if you're on your feet all day, your legs are going to swell a bit. And some of the serum from your blood vessels leaks out, carries with it some of the red blood cells. And red blood cells have iron in them. We call it heme because it's formulated to carry oxygen. But when that gets deposited in the skin, when it's outside of the blood vessel, it's like a tattoo coming from inside the body.
Totally.
And it is mostly a permanent pigmentation that starts to happen on the legs.
Totally. There's that one. Another one that we see, it's an inverse of pigment called idiopathic guttate hypomelanosis.
Yeah.
And that's something that we see commonly on the arms. I've noticed a few starting to pop up on my arms.
I have a couple as well.
Yeah. So instead of getting the dark spot, it's a white spot or a lighter spot that doesn't tend to tan. So it sticks out a lot in the summertime. Another issue with pigment that we see.
Yeah, pigmentation problems aren't just dark spots, although that's primarily what we're talking about today, but it can be light spots. We're not doing a deep dive on vitiligo or anything today, but that idiopathic guttate hypomelanosis, one, it's fun to say.
It's very fun to say.
And it's almost like the pigment cells just give up in that area. They've had so much damage, they're just like, I quit, and you're just going to be white here.
Yep. So we're done.
But it's not the same as vitiligo or anything. So So we've covered a bulk of the types of dark spots that people can get. So I've got a little did you know for you. Let's transition there, and we'll come back with all the treatments.
Let's go. What do you got for me?
Well, pigmentation, excess pigmentation, is one of the top 5 diagnoses that people seek out a dermatologist for. It is that common that it's one of the top 5 diagnoses.
I could see that. I didn't know the statistic, but we do see it so often in clinics. So that would make sense to me.
A lot of times they're coming in for something else, and then they also ask about that.
Yeah.
I don't know that it would be top 5 where that's the sole reason that people are coming into the clinic.
Yeah.
But I'm sure that as they do studies, they look at all the diagnosis codes that are used in dermatology, and that one makes it on there a lot, even if the primary reason that they came in was for a mole check or for a rash or something like that.
Sure. Well, I have one for you. We were talking a little bit about melasma being a hyperpigmentation that can show up on your face, and it's usually attributed to sun exposure, but heat itself can induce melasma, meaning if you're cooking over a hot stove or taking a long hot shower, things like that can actually induce the worsening of your melasma.
It's true. I remember when I was in residency, one of the residents that was a couple of years ahead of me, she had been pregnant, she had a baby, and she got melasma during that time.
Yeah.
And she had been working so hard to get it to go away. She was doing all the lightening creams that we'll talk about. She was religious about her sunscreen. And she went to Mexico with her husband on a trip, and she wore sunscreen every day. She reapplied frequently.
Yeah.
She stayed in the shade, but it was so hot that sitting under the umbrella in the shade, just with that heat, she came back and her melasma was completely flared up.
I feel so bad. Just can't win.
Yeah.
But
so, and it's, also kind of another did you know type thing is it's not just in pregnancy, but taking birth control pills can increase the risk for women as well.
Totally.
It's the hormones and the change in the levels of the hormones or exogenous hormones that can increase the risk for that if you're sensitive. There's some data that even blue light, like from your cell phones, might contribute.
Really?
I think it's a really small risk with the blue light because the intensity of the light off your cell phone is so minimal. Even if you're blocking UV, you get way more blue light from the sun because it has the full spectrum of light. And the sunscreens that we use are broad spectrum, but they only cover UV rays. And so when you're not being protected from blue light, and there's something called the opsin pathway in the melanocytes that can be triggered from blue light or from or heat as well. And so that's why it's incredibly frustrating, and it's why we recommend tinted sunscreens for our patients with melasma, because the iron oxide inside that also blocks the heat. It reflects infrared rays.
That's interesting.
So
I knew that we recommend tinted for people with melasma, but I never truly understood why. So
yeah,
there you go.
Well, now you know.
Now I know.
As we come back, we're going to talk about all of the treatments for pigmentation that you can use to help reduce or prevent unwanted pigmentation. And I think it will be of no surprise that we're going to start with sunscreen.
Yeah, that's step number 1 always.
Yeah. So what are the recommendations you have for patients who are trying to prevent or treat pigmentation when you're recommending sunscreen?
So for, let's just say, my acne patients who are coming in who we're treating their acne, but they have some PIH involved, I definitely recommend a zinc oxide-based sunscreen typically. My go-to recommendation, depending on the skin type, is the LTMD UV Clear. They have the sheer, and then they have the tinted version, and they both work great. Those would be, that's always step number 1. When we're treating things like melasma or other types of conditions, we'll add other medications to help. But using a broad spectrum, just like you had mentioned, and tinted sunscreen for specific conditions is always step 1. We start there. And a lot of times, if we're treating hyperpigmentation disorders and not doing that step, the other medications we're prescribing are just going to be useless. So.
Yeah. The same goes with lasers or any other treatments. Is there's nothing that we can do to you that the sun can't undo. I mean, the sun is stronger than everything else. True. So if you're not protecting yourself from the sun, then you're just never going to make progress. Yeah. And if you do have progress, it's not going to last once summer comes back around.
Totally. And I'll say the past maybe 2 or 3 months, the anti-sunscreen people online are doing some solid work, because I've had a lot of patients almost on a daily basis asking me, should I be using sunscreen? I've been seeing all these different TikToks and Instagram reels saying why I shouldn't use sunscreen. And we never will not say don't wear sunscreen if you're going to be outside.
Unequivocally, sunscreen saves lives. It reduces aging in the skin. It reduces pigmentation, and it decreases your risk primarily for basal cell carcinoma and squamous cell carcinoma. And there's some evidence that it also reduces your risk of certain types of melanoma. But melanoma is something that it can pop up anywhere. It can be in non-sun exposed areas. So obviously wearing sunscreen won't prevent you from getting a melanoma where the sun don't shine, and that can happen for other reasons. But I never miss a day of sunscreen. And I just always think, like, if sunscreen caused cancer, wouldn't dermatologists have the highest rate of cancer of any population anywhere?
We're just lathering it up constantly.
And dermatologists are not dropping dead from skin cancer on a daily basis.
No.
So just use some common sense. But there's people out there that have an agenda. They want to sell you some supplement or whatever it is. Unequivocally, just wear your sunscreen.
Agreed.
So there's a lot of topical treatments that can help. The first one that we commonly will use, it is prescription hydroquinone.
Hydroquinone usually has to be compounded for our patients, but hydroquinone acts on the enzyme tyrosine. It's a tyrosinase inhibitor. Basically what that means is it's trying to signal to your cells or your melanocytes to not make as much melanin. And it can take a long time. It can be frustrating for our patients. So if you're going into your dermatology provider and they're recommending hydroquinone, there's different formulations. There's an over-the-counter version. I think it's a 2%.
2%.
And the 2% really just is not very effective. I don't recommend it to anybody. But there's 4, 8, 12% formulations, and they'll have other ingredients like retinoids sometimes in it, kojic acid, niacinamides that can be beneficial. And the key is we always want you wearing sunscreen first thing in the morning and then using this medication at nighttime. And consistency is key. It takes a long time. So we have to kind of hold our patient's hand a little bit and remind them this is what you need to do. But we don't want you using it continually for months and months and months. We need to take breaks because of a side effect called exogenous ochronosis, which can lead to pigment in the skin. So the exact opposite.
Yeah. I think for this reason, there's a huge market for other ingredients that have come out. Some of them are very effective. But commonly, when we are going to use hydroquinone, I go a 12% hydroquinone. I don't give the patient any refills on it because I tell them, I only want you to use this for 3 months.
Exactly.
You have to put it on just the areas that are pigmented. Because if you just smear it generously around it, if you have melasma on your upper lip, let's say, and you just smear it generously and you're getting it out on your cheeks, it will lighten anything that it touches.
Everything. So it lightens together. And you don't get the effect.
And so then you get almost like white patches in areas that aren't hyperpigmented. And that ochronosis is a permanent pigmentation. So if you get hydroquinone and you find a source online and you buy a 6%, 8%, 12%, and you just start using it for a year straight, there's a good chance you're going to get this ochronosis. We don't, at least I don't know exactly why it happens, but you can biopsy and you see these globules of pigment under the skin, and it is permanent. There's no way to get rid of it. There's some research that using a 1064 Q-switch laser or maybe a picosecond laser can break up that pigment, but it's like tattoo removal that we've talked about. It takes many, many treatments. It's painful, it's expensive. And so you cannot use hydroquinone for more than 3 or 4 months max before you have to take a break of equal time.
That's exactly how I recommend it to my patients. I actually had an interesting case years ago where a patient had come in and she was getting these bluish nails. And we couldn't quite figure out what was going on. We weren't prescribing any of the medication. She came in as a new patient with these blue nails. After, I think, 3 or 4 visits of us, we did a clipping. We were considering doing a nail matrix biopsy. We couldn't figure out why are your nails. We did blood work, all these things. She mentioned offhandedly that, I'm getting hydroquinone from some online thing. And after doing a little bit of research, it can, if it gets on your hands and you're applying it, it can turn your nails blue or grayish blue.
Interesting. She wasn't washing it off afterwards very well, probably, or just using it too long. Very interesting.
So we had her stop using it, and it did fade a little bit. They remained kind of bluish, but it did start to subside a touch. So.
Once they grew out all the way, did it go away?
I don't know. We saw her after a month of stopping, and she's like, "Look," and we had pictures, and we're like, "It's getting better."
Okay, that's good. So you mentioned that hydroquinone is a tyrosinase inhibitor. That's the enzyme that takes the amino acid tyrosine and turns it into something called dopaquinone, and then ends up going back through the tyrosinase. It does it twice, comes back through, and then it makes melanin. And that enzyme is present in the melanocyte, so we use hydroquinone to block the activity of that enzyme. Another one that can do that is kojic acid. Kojic acid also acts as a tyrosinase inhibitor. It's the most common target of all of these creams that reduce pigmentation. I don't think kojic acid is quite as potent as hydroquinone.
Yeah.
When I compound it, I'm usually using 12% hydroquinone with 6% kojic acid. But kojic acid is something that's pretty easy to obtain over the counter. There's lots of dark spot treatments that you can buy at any local drugstore that will have kojic acid in there.
Yeah.
And I think it is a helpful adjunct, but I wouldn't rely on it solely to reduce your pigmentation.
I agree. Do you use retinoids often to calm down pigment in the skin?
I think retinol is something that is helpful for pigment, and I don't think it necessarily matters what kind of pigment you have. I do think it's particularly effective in that post-inflammatory hyperpigmentation to help improve the cell turnover, thin out the stratum corneum a little bit. That's the top layer of dead skin cells.
Right.
And with continued use, in addition to good sunscreen and maybe other treatments for pigmentation, I do think that retinol is a helpful adjunct.
Yeah, I agree. Oftentimes I'll have a retinoid or retinol in my compounds for pigmentation when I'm treating.
Yeah, it's a good addition. Niacinamide is another thing. It's kind of the jack of all trades.
It is.
We use niacinamide for acne, for pigmentation, for fine lines and wrinkles.
Yep.
But it has some activity on reducing pigment. Again, I think that's through the tyrosinase enzyme.
Yeah.
So again, it's not the miracle worker by itself, but it's something that's often compounded into other treatments.
Totally.
So any other treatments in particular you use from a topical perspective?
From a topical perspective, I have been recommending what we have here, the thiamidol from Eucerin, which acts along the same pathway as hydroquinone, but you can use it on all skin types, and it's readily available for patients. It's sometimes cheaper over the counter to get it, and I've seen actually really good results with it. Yeah.
So the Radiant Tone collection from Eucerin that we have here today, it uses a new ingredient called thiamidol that blocks that tyrosinase enzyme. And the advantage is that it has not been shown to be toxic to the melanocytes the way that hydroquinone is.
Yeah.
So you can use it continuously. They make it with a cleanser. So thiamidol is not actually in the cleanser. It's just a gentle exfoliating cleanser, but it has a serum that can be used twice a day, a morning sunscreen that has thiamidol in it, plus broad spectrum SPF 30, and then a night cream, which is your moisturizer that has thiamidol. So they've covered their bases pretty well with that regimen, and I do like recommending thiamidol. Another one that has got some really good data behind it is called melasyl. Melasyl is a proprietary ingredient that was developed by the scientists at La Roche-Posay, and instead of acting on the tyrosinase enzyme, it goes into the skin and it binds up the ingredients that will make melanin. So it binds to tyrosine and other things so that they're not available to go into the tyrosinase enzyme.
Sure. So it prevents it from getting
into the cell. It prevents it from even going into
the
the machine that turns it into pigment. So it kind of gobbles up the precursors. And so I like recommending multiple modalities.
Yeah.
And so you can use something like Mela B3 serum from La Roche-Posay, as well as thiamidol, because they work on different pathways,
right?
And you might see accelerated results. I'm not aware of any studies where the two have been used together, since they're from competing companies,
right?
And the data that I have seen from La Roche-Posay, they state that theirs is more effective than thiamidol, but it's a $45 serum. But once you buy all four of these products, you're spending at least that much as well. So again, I think it can be helpful to do more than one thing.
Yeah, I agree.
And patients can cycle their treatments. They can do hydroquinone, like a stronger hydroquinone, through the summer when things are likely to get worse.
Yeah.
And then over the rest of the year, they can use things like Mela B3, niacinamide, kojic acid, the Radiant Tone collection from Eucerin.
Yep. So. And on their time off from using hydroquinone, you can use something like that.
Have you ever used oral tranexamic acid?
I have not.
So tranexamic acid is something that is in a lot of topical compounds as well for pigmentation. It acts on that tyrosinase pathway, but they have found that taking it orally can also reduce pigmentation. And I saw a patient last week who I've had on oral tranexamic acid for maybe 3 years, and she loves it. Gets great results for her melasma.
That's great.
Tranexamic acid is given most commonly to women after delivery when they're still bleeding, because it promotes clotting in the body.
Oh, interesting.
But for some reason, it also reduces pigmentation.
Yeah.
And so this is not medical advice, obviously. When I have patients take it, they usually take a half a pill twice a day. And I usually recommend that they take a baby aspirin at the same time, just in case they do have any pre-existing risk factors for clotting. I won't prescribe it to somebody who takes birth control pills or who has a history of blood clots, just because it acts on that pathway that can promote blood clots if you're bleeding. So it is something you have to be careful for, because it's in medicine going inside your body. The risks are larger than anything that you use topically, but in the right patient, I've seen it work really well.
That's awesome. Yeah, I haven't used it just because of the risks, but I know that it can be really beneficial.
Yeah. Then there are a lot of treatments that we can do in the office that really work well on pigmentation. Do you have any favorites?
It depends on the severity, but if in lighter skin tones with melasma, I'll do a chemical peel sometime, and depending on they may need multiple a series of chemical peels, but chemical peels are typically really good. People who really want to go for it, maybe they have PIH, maybe they have acne scars and other things going on the face, lots of lentigines, or even growths like seborrheic keratosis that are macular, they're flat. The CO2 does a good job at just giving you a clean slate. But those are my typical, like, it'll depend on how severe my patient is and really how aggressive they want to be. But usually just a simple series of chemical peels do a good job. Yeah. That's typically what I recommend. You have to feel out each patient, but.
Right. Yeah, I like, if something is a very superficial pigment like those sunspots or post-inflammatory pigmentation, then the cool peel, like the CO2 laser at light settings, will work really well to brighten the skin. Or a BBL treatment, or we just got the Modus Pro laser, and they have a pigment treatment on there with the 755.
Oh, I know there's a pigment setting.
And I just saw our first before and afters, because we've only had the laser for maybe a month. Yeah. And we just saw our first before and after on the pigment treatment, and it was amazing.
Really?
Yeah.
I'll have to look at that.
It was really impressive.
That's awesome.
Now, the caveat here is that if you have melasma, lasers sometimes can make it worse because they generate heat. And like Austin mentioned, heat sometimes will trigger your melasma. And so we don't use BBL or the Modus Pro for our melasma patients because the heat that it generates is just too much. Yep. The halo laser that we have can be helpful, or the clear and brilliant, because it doesn't generate as much heat in the skin. But I think the gold standard for laser treatments is, again, going to be like the Q-switched 1064 laser or a picosecond laser, because they can fire so fast, they just don't generate a lot of heat in the skin. Right. And so you can break up the pigment without leading to heat production that triggers more melasma to develop.
Right.
So.
Interesting.
But that kind of wraps up the treatments. I agree with you that chemical peels serve a role, laser treatments. Microneedling in post-inflammatory hyperpigmentation, I think, can be helpful to help break that up. So, but microneedling is not something that I see a lot of results for in lentigines or in melasma. Yeah. So.
And we kind of discuss things to avoid, such as excess heat or sun exposure when you're treating hyperpigmentation. Is there anything else that comes to mind?
Well, if heat is a trigger, sauna is very popular. Sauna could be a trigger as well. So you have to be super careful in things that might otherwise you really like doing. And I think if I developed melasma, I don't know that I could stop getting in my sauna. I love sauna.
I love a good sauna. I love a good hot tub session. Yeah. It's hard. And a nice hot shower at the end of the day in the wintertime.
So, but you do have to be careful. Determine what your priorities are and how aggressive you're willing to be treating it. But most importantly, if you're not seeing results with over-the-counter treatments, make a plan with a dermatologist to tackle that pigmentation, because oftentimes good progress can be made with consistent treatment.
Yeah.
So,
agreed.
As we wrap up, the product of the week is the Radiant Tone collection from Eucerin. We'll have links to all of these products in the podcast show notes or on the YouTube video description. The Radiant Tone cleanser can be used once or twice a day. It's got AHAs, alpha hydroxy acids, so lightly exfoliates. You can use the other products up to 4 times a day, usually the serum morning and night, the sunscreen in the morning, and the moisturizer at night, and you're getting that thiamidol on the skin to reduce pigmentation without risking your pigment cells developing ochronosis or that toxicity. So I'm very happy with this line. I've reviewed it on my YouTube channel, and I've seen good results as patients have used it as well. Lots of good before and afters online on skincare addiction on Reddit. I've seen people praising it too. So, Radiant Tone Collection. And we'll leave you guys with that. I'm Dr. Dustin, board-certified dermatologist. You can find me on social media at Dr. Dustin Portela. As well, I'm on Substack now. So if you want deep dives into skincare topics, check me out on Substack. We'll have a link to that down in the podcast show notes.
And I've read a lot of your Substacks, and they're really good.
Thank you.
They cover a lot of things, and they break things down in a way that are easy to understand. So, and I'm Austin Lee. You can find me at Austin Lee PAC at most social media platforms. And I'd love to hear any questions or concerns or other things that you have for us. And then we have our Skinfluence pod.
Yeah.
Skinfluence_pod.
On Instagram.
On Instagram.
So follow us there. DM us your questions or comments or feedback. We have thick skin most of the time, so we can take your criticism.
Yeah, we try.
Thanks for joining us, and we'll catch you guys on the next episode.